But we are joined first by Bill Wilkerson. Bill is the executive chairman of Mental Health International. Bill, it's been just over a year since you and I have had a chance to chat.
It's been a long time, and I'm looking forward to it and glad to be with you today.
Let's start off by talking about Mental Health International and how that came about. You're one of the founders and the executive chairman.
Sure. Actually, it was preceded by a thing we called the Global Business Roundtable on Mental Health at the Honorable Michael Wilson, our distinguished former finance minister and ambassador of the United States, and I set up, who passed away a couple of years ago now, 2 years ago. And we did that to bring business leaders into the know about the effects of mental disorders on their people, on their business, on the need for their investments in trying to support people through these conditions. That took us through from the late 90s through to the mid, I guess around 2011-12. We created Mental Health International as a vehicle that took me to Europe for 4 years, where we eventually did the same thing. We brought business executives from major European capitals together in small groups to talk about the economic cost, the difficulties posed by work environments that were highly stressful and toxic in nature, and how people who were suffering needed their support. And we've been doing that through the last several years, and I'm now nearing my 25th anniversary of this accidental mission of mine around mental health, and I've got one more thing in me, I think, and we'll kind of wrap it up, but I'll talk to you about that in a minute or two.
All right. Talk to us about how you got into the mental health field. How did it become an interest? It
became an interest when I was the chief executive for a health benefits company, which was called Ontario Blue Cross, became Liberty Health. It's since changed again, but I saw a trend in prescription drug use that drew my attention to a certain general ambiguity about why people were having trouble sleeping to such a degree, pain medications, a sort of difficult to pin down series of trends. And we looked into this, and I eventually engaged with Harvard University, and we learned of the rising rates of depression and anxiety disorders. And that became quite an enlightening experience, and we decided to try to do something about it, and that's where I began this effort.
Do we know where the rise in this at that time began, where became more depression, more anxiety? Was it just being diagnosed, or is there extenuating factors?
Yeah, there certainly were real reasons it was happening. There might have been some influence by way of a greater diagnosis. I don't think so. The data we have showed us that society was changing. People were losing their jobs. Support staffs were being replaced by technology. We also saw a higher rate of cardiovascular illness connecting in with depression. And as I mentioned, my apologies if I'm scratching, my allergy season. And the crossover effects between various chronic disorders and depression and anxiety was established in those years. It's the late 90s. And so we saw a real concrete growth and spread of these conditions, which were still highly stigmatized in those days. That's 20 some odd years ago. They were not viewed as real. People who claimed to be suffering these conditions were looked upon as troublemakers, as weak, as causing the problems themselves. So our job right off the bat was to try to break down those barriers, and we did so pretty well. Corporate Canada responded well and got informed. And once you can get informed and you're interested in solving a problem, you can do it.
And has there been progress in solving the problem? Has the stigmatism lessened over the last 20 years or so?
I think so. I think we can say it is. People will still say it's stigmatized, and I trace that to something other than discrimination. I think actual discrimination, at least the kind that is clear and concrete in the way we do policies and practices in government or business, is much reduced. But stigma continues in another more elusive way. We hear about systemic racism. We still have these systemic features of the stigmatization of mental illnesses, and that's embedded in the fact that we have not only not a good mental health care system in Canada, we don't have one at all. And while I have nothing but highest regard for the folks at NHH or other people in communities doing service work for those with mental illness, I'm not referring to them. I'm referring to the fact that if you have concerns about yourself or a family member, good luck in making an appointment anytime soon with anyone who can actually professionally help you. So that's the underlying problem of the day: lack of access to care, lack of understanding precisely what causes these conditions. We got a better overall sense for sure. And thirdly, we just do not have a system of healthcare to accommodate this kind of misery.
And has that changed at all over the years since you started working in this field? Is it getting any better? And if not, why? Like what is the stumbling blocks for this to move forward?
I think there's several. Number one, the healthcare system remains rooted in a culture of physical care. And yes, it's changing a lot, but you try to get an appointment with a psychiatrist today, and I know a lot of them, they're all working 24/7, but there's not enough of them. Secondly, they're getting older. The mental health care workforce is becoming the oldest segment of the healthcare professional industry we have. And that will also take its toll in the years to come. So we've got to move away from the idea that we've got to see a doctor each time that we're facing one of these crises. And we've got to have a wider range of professionals qualified to help, but also within the context of a system. We don't have that now. It's good luck, accidental access, great human efforts on the part of nurses and practitioners and doctors and emergency care personnel. They're fighting mental illness the way we've been fighting the pandemic, by the seat of their pants. And that's been going on for 20 years. I hope we can change that. And that's going to be one of my last hurrahs, if you will, in this field of endeavor.
You led to that a couple of times. So let's talk about that now. We can come back to a couple of other things. So you're spearheading an international prevention plan at Centennial House in Port Hope.
Right.
Talk to us about this.
My work has been international, and I was recognized by McMaster University. They lowered their standards just enough to give me an honorary doctorate of laws to celebrate, frankly, that there was an international dialogue going on with regard to mental health, and there now is. So that's point one. Point two, we know enough now to not wait for the big breakthrough discovery, to start to work to prevent the disabling, the deadly, the miserable effects of these conditions. And that's what I feel we must now dedicate ourselves to. It's got to be a societal effort. It's got to be a scientific effort. It's got to be a corporate effort. It's got to be a way we treat each other, as well as the way we treat each other as human beings, that is the way we treat each other medically. And at the heart of this is this. We now know the following. We know that mental disorders complicate and raise the risks of cardiovascular illness. We know that mental disorders, especially for those living with diabetes, heighten the risk of sudden death due to heart attack. Thirdly, we know now that mental disorders increase the risk of sclerosis problems, veins, potential of stroke, even among young people, and it is now classified as a pediatric condition of concern. We also know that when you look at the death toll from COVID, as tragic as that is, part of the vulnerability there has to do with the crossover effects between mental distress and chronic disorders, including lung disease. So what we have is a tremendous incentive to do better. Secondly, prevention of risk. That's what this is going to have to be focused on. We know enough about the causation to know where the risks are. However, this is a big deal. We're going to have to tackle the risks associated with societal behavior. For example, social media is going to have to be reformed, no question. Secondly, we're going to have to be very clear that institutional decision-making by governments, by corporations, have very specific effects of a very specific nature when they evoke fear, loss, or fear of loss. That is also a characteristic of the distress coming out of the pandemic, is loss and fear of loss. And thirdly, we've got to get at the anger underlying our society. And there's a significant portion of the population is alienated through its anger of exclusion. All of which leads us to suggest two or three things. One, if we know what the risks are, let's reduce them. There's a nutritional factor here. Higher rates of starvation and higher and less nutritional food availabilities can produce brain changes that induce mental disorders. So there's everyday things like diet and food access, housing security, racial behavior, racialization of families and groups will evoke a reaction between here and behind here that can induce depression. So we have, I think, an opportunity in this world today, having gone through this pandemic, realizing it means we got to come together, be the slogan we've lived with now for a year plus. And we've got to have a chance here to get at cause. Cause is from two channels. One, some of this we inherit through our genes from our parents, but not much. Most of it has to do with our prenatal and our postnatal experiences with getting born and living our life. And so it's how we as individuals, as human beings, treat each other is collectively the single greatest cause of mental disorder, born of mental distress.
So you take this right back to birth. Is the way children are being brought up, has it differed so much that this is becoming more of a problem over the generations?
Don't think I can say that. I wouldn't know the answer to that question precisely, but we do know some things that have been well established for a long time. Number one is child abuse. To me, that should be a capital crime because it can influence the well-being of the child, not only through the horrible experience of the event and what flowed in and out of it, but for the rest of their lives. They develop tendencies and attitudes and perspectives that are unhealthy through that formative experience. And secondly, it has a lot to do with the fact that we know mental disorders are a neurodevelopmental condition, which means they start very early in life. And we have genetic insights now into schizophrenia, which tell us this. And they flow along a lifespan. Sometimes they don't materialize early, sometimes they do. But we have some instruments available to us. We have love, peace, opportunity, housing, security, inclusion. These are the fundamentals of a hospitable world. And funny enough, the way we're going to solve mental illnesses is going to be a test of how really true we are to creating an environment of life that we all can sustain ourselves and prosper in. It's a great test, finally, and ultimately, of what we keep saying we want to do and what politicians claim to be trying to do as to whether, number one, we really want to do it to love each other or whether we can. And that what I'm preparing, and I'm having a discussion tomorrow with the former Governor General David Johnston, who's very interested in this, and he's writing a book all about leadership empathy. And empathy is a very important tool in this because empathy, which is not sympathy, empathy is understanding where another person's suffering or disquiet or concern is coming from. And that is, to me, a big part of the learning curve that's going to have to go on rather dramatically, where we combine medicine, science, economic investments, human affairs, and the sense of community into a unified package. And these are things we knew we had to do anyway with most chronic illnesses, to untangle depression from so many of these other chronic conditions like heart disease and cancer, in order to create a chance for the people in the hospital service area, in the community service area, law enforcement, who are doing wonderfully dedicated work, but are doing it at a great disadvantage because there's no system behind them.
How challenging is it to get that universal, that empathy when you reference social media and the drastic changes that have to happen there? It seems that social media is taken to a point right now where it's just going in exactly the opposite direction.
Yeah, it is. And there's neuroscientific evidence of this. One of my initiatives in this regard, or at least what I hope to be able to do, is to question the standards of ethics around neuroscientists who are working for the social media companies, because they're designing them to reach, just as the smoking manufacturing or the cigarette smokers and the cigarette manufacturers did. They're designing these things to produce an addictive effect. You don't do that by guesswork. You do that with brain science knowledge. And neuroscientists are working for these people, just as respirologists work for the cigarette makers and the addiction specialists work for the cigarette makers. That we have to get at. The second part of it is we're going to have to develop a discipline to simply turn this stuff off. And I know that sounds, sky in the pie or pie in the sky, but it's absolutely essential. We are driving each other crazy. And I have just finished a series of talks with the government of Canada and many of their employees, several hundreds, about multitasking. That's a neuroscientific, a brain science impossibility to juggle effectively. And yet we do it. And that's being pushed and promoted just innately by the kinds of internet uses that we currently have today. If you look at a screen, you'll see it all jumbled up with different things of size. And that's a fundamental premise behind multitasking, which is an impossibility to do effectively. And yet we force ourselves into that. We have created, take a look at the 401. Get on there, and pretty soon you see the movement of traffic horizontally and laterally. People are in a hurry to nowhere, and they're juggling and they're struggling to get something done that they should be able to given time to do it in an orderly fashion. These are both symptoms of and kind of causes of the highly stressful world that we've created. Urbanization is a big part of this. I should mention this prevention strategy has a big nature piece. We have lots of clinical evidence how beneficial a walk in the forest is. And we're fighting to preserve trees here in Port Hope, my local front, for this very reason, that our natural and our nature connections are really important to our own well-being. And we have rivers and diversity of a wonderful level and sort that's at risk through the expansion of suburbanization, and we've got to stop that too.
We got a huge job in front of us. I could spend the entire hour talking to you, Bill. We certainly want to talk to you before another 14 months is up. Thank you very much for taking the time.
My pleasure. Thank you so much. Appreciate it.